Over here we're in the University Hospital Groningen in the Netherlands, and this video will guide you through the lung volume reduction coil treatment procedure. The lung volume reduction coil procedure is a really unique procedure since it's flow independent, and a lot of patients we treated so far using other devices, we see sometimes that it doesn't work because there's a lot of collateral airflow, and the big advantage of the lung volume reduction coils in our opinion is that it's really independent of the airflow. So you can put the coils into the main segmental airways and it retracts the lung tissue, and you improve elastic recoil, and you prevent dynamic hyperinflation from occurring. And that's, we think, why the majority of subjects also respond to this treatment.
Before the treatment, the patients are very disabled. When they do exercise, they are very exhausted after walking a long distance. But after the procedure, you see a big difference. They are less exhausted and they can walk a longer distance than before the procedure.
Another really important issue in identifying subjects for this treatment is that they really need to have a severe stage of emphysema, so gold stage 3 or 4 with severe disability. So let's say a 6-minute walk test should be limited somewhere around 400 meters. And also when looking into their pulmonary function test, they really need hyperinflation, so high TLC and high residual volume together. And those candidates seem to be very suitable because they have enough disability to get a proper response. Currently we're focusing on treating patients with heterogeneous emphysema, so with merely upper lobe destruction and preservation of the lower lobes. And sometimes it's the other way around, and there should be a difference between the upper and the lower lobe. And the coils work in almost all grades of destruction from 0 to 1 to 2 to 3. And it might be that in emphysema grade 4, so over 75% of destruction, they might not work that good because the coils need some tissue to give support. So when there's only air, you can put in coils, but then they won't be able to retract tissue. So that's one of the major criteria we're looking for. So this is the bronchoscopy suite of our hospital, and today we're going to treat a patient with very severe emphysema with lung volume reduction coils. It's a second treatment, and we treated the left upper lobe about a month ago, and today we're going to treat the right upper lobe with lung volume reduction coils. We have our own in-house protocol, so we have a standard protocol to prepare patients for bronchoscopy and for treatments like this. So we start 5 days in advance using an oral course of prednisolone, and as of the treatment day up to day 8 we continue that low dose of oral prednisolone, 30 milligrams, combined with azithromycin once daily. But you can also use your own local protocol, which you use in these severely disabled patients. The lung volume reduction coil treatment in our hospital is performed under general anesthesia, and depending on the amount of destruction between upper and lower lobe of both lungs, we decide on what lung to start with. So the lung that has the biggest chance of getting the proper improvement, we start with that lung. So we can start. Today we're looking for the right upper lobe. So left, right upper. So then we introduce the catheter into the bronchoscope. This is the actual catheter, and it's designed to be atraumatic, but it's still open, so in theory it can induce harm to the lung tissue. So always make sure that the atraumatic, flexible guide wire is in front of the catheter when you're inside the airway. But the first step is identifying where your major airways are using the guide wire, and also assessing the length of the airway. When starting to placing a coil, we first advance the catheter into the bronchoscope and leave it just outside the bronchoscope.
So here's the right upper lobe, so the posterior segment, apical, and the anterior segment. And I will start in the posterior segment over here. So now we push forward the guide wire.
And then enter the segment and then really let the guide wire do the work. So put on your fluoro, put the guide wire into the lung and advance it until you see a little bit bending.
And there you see it starts bending.
Then you know you reach the pleura.
And then we retract a little bit, like this.
One important thing is just to make sure that the guide wire, which is visible over here, is always in front of the distal end of the catheter, which is shown over here. This is the marker of the distal end of the catheter. And the catheter is a little bit more stiff and might theoretically induce more harm to the tissue. So always make sure that the atraumatic part is in front of your catheter. And when the catheter gets to the place where the guide wire bended, align both and keep a safe distance there from the pleura, let's say 15 millimeters. And then shut down your fluoro and really measure the number of markers on your guide wire. The sizing of the coils is pretty straightforward. So you can count 1, 2, 3 markers. And 3 markers means 25, 50, 75 millimeters. And I always oversize 1, so this is 100 millimeters for coil size.
So there's your first marker coming here, second marker here, third marker there. So now we count 1, 2, 3. Ja, 100 mag je eruit.
When I do the sizing, I mention the coil length to my assistant and she starts loading the coil. Then remove the guide wire, leave the catheter in place and then wait for the coil to be loaded. Assistant advances the biopsy forceps through the cartridge and connect the biopsy forceps head to the proximal end of the coil. Make sure the biopsy forceps is tightly closed. And then gently retract the coil from the shell into the cartridge. And the whole system, so the cartridge with the coil inside and the biopsy forceps connected to it, is carefully handed over to the bronchoscopist assistant. And then your assistant or colleague will put the introducer, connect the introducer to your catheter and easily advance the loaded coil with the biopsy forceps inside the catheter until the point that the catheter is almost inside, and then you put on your fluoro again, and under fluoro you see your coil advancing into the catheter. An important step there is really to align the distal end of the coil with the distal end of the catheter, which is pretty easy.
So now we connect the cartridge to the catheter and push for advance the biopsy forceps and loading the coil into the bronchoscope. And there it comes into the catheter and we can align the coil and the catheter.
And once it's aligned, you switch gears, then you hand over the bronchoscope to your assistant and you take over both the introducer and the catheter. And then the actual deployment can start.
Now we switch gears. I hand over the bronchoscope to Ali.
One important tip is at the moment you hand over the bronchoscope to your assistant, is that the assistant really focuses on the distal end of the bronchoscope, because the assistant has to make sure to keep the bronchoscope over here. So the assistant should not focus on this, but really focus on this, to keep the bronchoscope over here.
And then I make sure that the first part of the coil bends like this. Now simultaneously retract the catheter and push forward the coil, and it deploys.
At this screenshot you can see the coil which has just been deployed. It's still solidly fixed inside the biopsy forceps head. And over here you can see the distal end of the catheter which has been totally pulled back.
And now we switch back and release the coil. So we release the grip.
And under fluoro it's very easy to see opening of the biopsy forceps head, and you can let it go and then the coil is released. The procedure itself, it's pretty straightforward, and you repeat your procedure, let's say about 8 to 10 times when placing 8 to 10 coils, and in our hospital we maximize the treatment to 10 coils.
So you can see the coil coming through the bronchoscope, and we align the coil with the distal end of the catheter. Okay, and through the bronchoscope you can see the biopsy forceps head. So now we first retract the catheter a little bit until the coil makes the first bend like this, and now we advance the coil and retract the catheter at the same time and make sure the biopsy forceps head stays out of the bronchoscope. Okay, stop maar. So now we release the coil, so open the biopsy forceps like this. Doorlichten. And on the fluoro you can see it releasing the coil. Stop maar. And we go for the next segment. So it's just fishing for a new airway. So here we have a new airway.
I always use the same algorithm of treatment. So start at the posterior segment, go apical and then go anterior. And when I treat the left lobe, I first start at the apical posterior segment, then go anterior and then go to the lingular segment. And I always use the same order, so you never forget segments or subsegments. And when you're inside a segment, there's always branching in 2 and sometimes in 3 subsegments, and you're always able to treat those 2. The main issues here are that you really use no force in advancing the catheter up to this place. It might be that the catheter gets stuck over here and that you're not able to advance the catheter. At that stage you either have to decide to place a smaller coil or just go for a different airway. No, this was really a straightforward, uncomplicated procedure. So we always try to work very smooth, so don't be aggressive. So always keep a safe distance from the pleura. Make sure you don't use too much force to advance the catheter, so always stay on the safe side. And in between communicate with anesthesiologist to make sure that the anesthesia is also smooth. And no, there were really no complications in this procedure.
There are a few examples. After the treatment, patient told us that they start doing housekeeping again, also going into the garden and do some gardening. Also walking stairs goes much easier. And there are a few people who start working again, and they are very happy that they can take part of the social life and working life again.
And the procedure itself is technically not very difficult, so you need about 3 to 5 procedures for your learning curve to really be up to scale. And the training itself involves watching this video, visit the site where they already perform procedures like this and actually watch the full procedure. And when your first procedure is planned the day before, come together with your entire team to do a hands-on training using all the catheters and coils we're using, so that every step of the procedure is practiced by the entire team. And after that, the procedure itself, your first procedure really should be a supervised procedure by someone who is used to working with this device.